Hello, everybody. I hope you guys are doing well. Today, we're going to talk about all things overactive bladder, and I'm very excited to get to talk to Dr. Lake here. How are you, Dr. Lake?
I'm good. Thank you for inviting me.
Oh, thank you for taking the time to come here and chat with us. So, would you mind introducing yourself for our audience, please?
Sure. My name is Dr. Amaro Lake. I am a urogynecologist in private practice here in Seattle. I've been here since 2017 and started my private practice in 2019.
All right. So, what's urogynecology?
Urogynecology is the specialty of the pelvic floor. Basically, I trained as a gynecologist, and then so I did the OB/GYN residency, and then I did a further specialty fellowship training in the pelvic floor. So I take care of the bladder, the vagina, the uterus, and the part of the vagina that shares a wall with the rectum. So that I take care of that when it comes to prolapse. And then I take care of leakage of the urine and the bowels. So just a special training and focus on the pelvic floor. Some female pelvic medicine specialists can also be urologists, but I come from a gynecology background. So.
Yeah, thank you for that clarification because often it's confusing and people don't know urogynecology as a specialty and what are some of the reasons why they should be seeing a urogynecologist. So thank you for that because that helps clarify things that you guys look at, right? So from a urogynecology lens, what is an overactive bladder?
Yeah, overactive bladder is basically the theory that is currently upheld is that it's an overactivity or excitement of the bladder muscle. So the bladder is a muscle that's shaped in a bag, kind of, and we think that the muscle of the bladder with overactive bladder syndrome is overly excited or stimulated, and that causes people to have the symptoms of urgency, where they have this urge to pee that they just cannot avoid. Frequency, they often have to pee very frequently. They can't hold it for very long. And then oftentimes they leak on the way to the bathroom, like when they're trying to get there in time. So I like to describe it to my patients as, or many times they'll describe it to me as feeling like they have to pee right when they put their key in the door or right when they get into the garage or something like that. So it's just this sensation of inability to defer the urge to pee that can interfere with your life and cause bother. So.
Yeah, that key in the door syndrome is real. Like 1 minute you're fine, and 1 minute there's this sudden urge, right? So, what are some of the things that go into it? Like, why do people develop this?
Yeah, so one of the things that can make overactive bladder syndrome a little bit frustrating is that we don't actually have a cure for it. And so anytime there is the name of a diagnosis with a syndrome behind it, that means that essentially it's a compilation or a group of symptoms that have been put together and unfortunately we don't have a real well-defined reason for it. And so then many times in medicine also, there's no cure for it. So we think that so what we do know about it is that it's much more common as we get older. It's more common in women than it is in men, particularly in women of middle age. So anywhere from the 40s on into the 60s and 70s. And we also know that there are some exacerbating factors, some things that make it better. And so really our goal once someone is bothered enough by overactive bladder is to treat the symptoms, try to make things less bothersome so they don't have to avoid the things that they enjoy doing so much.
Yeah, so it seems like it could be slowly developing, and it's sort of like, which is at least what I see all the time, is it's been going on for many years, and women just change their life around it. Like they will start to use the bathroom in anticipation. It's that person who goes to the mall and knows where the restroom is before they even go to the store, kind of thing. So, what are some of the markers where it's at that point, okay, go see a doctor? What's
Yeah.
that? Because it goes on for so long, it's just hard to know when have you kind of adapted to it, or when is a good time of now actually go see a doctor for it.
Yeah, most definitely. Well, a lot of times I'll hear women that they'll go to the doctor and make their primary care doctor, and that person will make sure there's no infection. So we do make sure there's nothing physically or medically going on that can be treated that would help resolve the symptoms first.
Mm-hmm.
And so in some sense, overactive bladder or OAB is a diagnosis of exclusion. But in terms of when to see the doctor, typically it's when it starts to bother you or when it comes onto your radar as something that is not normal and that is interfering with your quality of life. That's usually what I tell my patients. So you mentioned toilet mapping. That's one of the coping mechanisms. And by the time people are toilet mapping, they're pretty far gone into the process. That means that they know where all the bathrooms are in all of the areas that they usually hang out.
Mm-hmm.
Some people avoid drinking water throughout the day, or they, stop drinking water at a certain time of the day. So anytime you notice that you're starting to make some of these adaptive changes in your life, or maybe those changes aren't working anymore to keep you dry or to keep you comfortable. A lot of times I get the sense from patients that it's just this sense of a lack of control or just a lack of predictability that makes it so frustrating. And believe it or not, people they start to say, I can't live like this anymore. So it doesn't have to be that severe when you seek medical attention. But a lot of times, as women, we do tend to take care of many different parts of our lives and our dear ones. And so for many reasons in society, we tend to put things on the back burner for ourselves. And that means that we don't reach out until maybe we're wearing more than one pad a day, or we're soaking through the pad now. We have to carry underwear with us. So things like that. So I like to encourage women to, first of all, just try to be aware of yourself and your body. And then that should let you know when something is off. And it's good to come in as soon as possible. Really, it doesn't have to be like your whole life is upside down because you're leaking all the time.
Yeah, and you said it very correctly that everybody's tolerance to that is different, right? Some people do wait a really long time and just adapt just because other things are taken over. And it can be hard because when I try to get history from patients, very commonly people will not be able to tell me when this started. Very commonly they feel, oh gosh, I feel like it's been forever, right? So we don't even recognize how much we have adapted life to accommodate for the bladder. And the frustration is real. I hear women say this all the time, that my bladder is taking over my life. So I guess what I gathered from this is everybody's level of what they're ready to put up with is different, but there is no such thing as seeing the doctor too soon. So whenever you feel like it's interrupting your life enough for it to be a bother, go see a doctor to rule out common things like infection. And if everything else is negative and you're still struggling, then we're talking about looking into this, right? So what
Absolutely.
is there a way to confirm it? Because is there a test, or is there anything that tells you, yep, you have overactive bladder?
Yeah, unfortunately not. It's really a diagnosis that's made clinically.
Mm-hmm.
We make sure that there's no physical reason on exam that there could be irritation or overactivity of the bladder or the urethra. And then we also, which is where the bladder empties, and then also make sure there's no infection by doing a urinalysis. Sometimes there are some medical conditions that can manifest as overactive bladder. So high blood sugar, so diabetes that's either not diagnosed yet or not very well controlled. If there's a lot of blood sugar in the urine in the kidney system, that can irritate the bladder. So that's the kind of thing that if you go see your primary care doctor first about this issue, they would screen you for that kind of,
Yeah.
too much glucose in the urine and indicating that there's a blood sugar problem, but yeah, there's no specific test that diagnoses it once we've excluded other factors. Yeah, so that also can be a little bit frustrating because as humans, we tend to want an answer. We want, okay, yes, this, not that.
Yeah.
But a lot of times in medicine, we usually can just say, okay, well, it's not that. It's not cancer, and it's not going to harm you. You don't have an infection. You don't have, horribly uncontrolled diabetes. But this is, as you already know, can affect your quality of life. So one of the most severe cases that I tend to run into in my patients is they've planned a trip, for a long time, like a year or something. They plan this big international trip. And over the course of, from the time that they get their tickets until the time that it's time to go, their urine control problems have gotten worse. And they realize that their suitcase is going to have to be full of pads.
Yeah.
And not only is it embarrassing, but it really hits home for them at that moment when they realize how much of an investment and how much of a focus their bladder has become. And so, yeah, it's really, the patient really tells you the diagnosis, as in most other conditions.
Yeah, I hear you. And you're right. It could be unsettling to hear that I don't know what it is, but I do know what it is not.
Yeah,
And
exactly.
but it's good for people to hear that there isn't like a gold standard test that will confirm that. And sometimes it can be a frustrating answer. It can be something that you don't want to hear, but sort of, like that's that's the name of the game with overactive bladder. So what are some of the things that are like, first line of treatment if people are experiencing these things?
Sure. So, well, physical therapy is, of course, I have to give props to my physical therapy friends. Yeah. So many people are very familiar with physical therapy for their shoulder or their hip or their back. These are much more socially acceptable and like kind of more normal body parts that are discussed when there's an injury. And so they're often very surprised when I tell them there's physical therapy for the pelvic floor. And the physical therapy, I usually advise them that it offers very low risk for very high gain. And it also puts you in a position of being very empowered because you gain skills by going through these sessions, usually 6 to 8 weeks weekly for one full session, a treatment session. And so you come out with more tools than you started. It definitely puts you in a very proactive position as opposed to taking a medication or kind of receiving other types of treatment. So definitely physical therapy, most patients, over half, end up wanting to do physical therapy. The other first line treatments, so there are certain drinks and foods that can be irritating to the bladder. And those are many times some things that we think we rely on to keep us going, like coffee or chocolate, alcohol, things like
All the
that.
good stuff.
All the good stuff, all the stuff that's socially just, you're supposed to have that mug and you're supposed to have the wine at the end of the day. And so, yeah, there's your mug. So those things in excess can definitely irritate the bladder. Usually I notice a lot of difference in patients if they're drinking 3 or more cups or 8-ounce servings of coffee a day. Then that's kind of the tipping point where, okay, if you decrease, you might notice some difference. You probably will. So there's things, bladder irritants in the foods as well. So anything acidic, like tomatoes or strawberries. There's a whole list of foods and drinks that are very specific to each patient. So it's more just an opportunity for her to become aware of her body and what makes her bladder more irritated. The other thing that it's a little bit touchy to talk about sometimes because everyone's trying to lose weight. We're all like, either on the treadmill or now everybody's on Peloton. But and, you know, or we're supposed to be at the gym. But there has been research that shows that decreased body weight by about 10% can significantly improve one's urinary symptoms. So that includes leakage, both with activity, which we're not talking about much today, cough, sneeze, leakage, as well as overactive bladder. And so that's another thing that is much overlooked and can really put patients in a position of empowerment to realize, oh, well, I mean, there's another reason to try to make some time for myself to either walk or do something that will help my overall health. So
yeah, and that can be tricky because for some people it's like a vicious cycle. If I can't exercise because my bladder, and then I need to exercise for my bladder, and it can be a struggle. And that was a great point about like bladder irritants, which are some of the things you can do on your own. And uh, as one thing I wanted to just clarify for people is, awful lot of times it feels intuitive to just restrict your water intake because you feel like you pee all the time. So what's the point? So people just intuitively start decreasing water intake, but all that does, it makes your urine so concentrated that that itself is a bladder irritant. And that's when you start to notice all these trips to the bathroom where nothing comes out of the bladder, right? So sometimes it's about decreasing what you're taking as an irritant, and sometimes it's about increasing water to, kind of balance it out. But let's say if somebody's going medical route, like what are we talking about? Like, are these medications that have to be taken forever, or do they take it for temporary relief and all of that stuff?
Yeah, you brought up a really good point, Darshana. I wanted to add on that not only, can concentrated urine cause irritation to the bladder, but it can also dehydration can put you at risk for an infection too, bladder infection. Yeah. So there's.
Thank you for saying that. Yeah.
Yeah. Water is your friend when it comes to the bladder for sure. Yeah. So the medications, as you know, they're marketed and studied to be taken forever. They want a forever client. And so that's how they're prescribed typically. There are two groups. One group is called anticholinergic group of medication. And that basically works by slowing down the bladder contractions. So urogynocologists and urologists used to use this group of medications. There's about 5 of them in that group. We used to use them very freely. And patients responded to them pretty well. But then there became mounting evidence and concern that it was linked to mental status change and cognition. And so finally, I want to say it might be 2017 or even before then, there became some research that was published, and kind of the research was duplicated to show that this group of medications does have an associated increased risk of dementia. And so the common side effects of this group are dry mouth, dry eyes, constipation. Those were some pretty tolerable side effects. But with the research showing that any use of this medication greater than 3 years can be associated with dementia, it's really caused a dramatic decrease in prescription of these meds. Nobody really wants to sign up for dementia. So so there's that group. And some people who are still using that drug, you can continue with careful monitoring. People notice a sharp difference in their urinary symptoms when they try to stop it. And so it makes it tough, like between a rock and a hard place. Like, should I, stop this medication and then suffer the leakage, or should I continue and kind of tread lightly? So in special cases, it can be continued, but it's really not hard. It's not easy to find the signs of dementia until after. There's no
warning signs.
Yeah, exactly. So you could take an exam, like a paper exam where you draw the picture or you draw the clock or things like that. But if it's abnormal, then that means that you already have problems. So it's tough.
Yeah, and when you're talking about things like cognitive decline and dementia, I think most people would be risk averse with that because we know that is not reversible. It's not like you stop the medication and you go back, right? So,
Absolutely.
I mean, I feel like very few people at that point are still bargaining between benefit and risk, right? It's kind of like
Absolutely.
feels like a
Yeah, definitely.
yeah.
Many people who are just don't consider starting it anymore. And so it's a very small fraction of people who've been on it for decades already who just say, well, the heck with it, I'm just going to keep going. Um, so there's a newer class of medications. It's really just one drug in that class, and it's called mirabegron, and it's a beta agonist, a beta 3
Mhm.
agonist. What that means is it's a drug that it can relax the muscle of the bladder. Instead of stopping the contractions like the other drug does, this one, it helps to prolong the filling phase of the bladder so that you have more time in between peeing and you have less of that urgency. So similar to all medications, it has side effects because they're similar tissue in all over the body. And so those receptors, the beta 3 receptors, or those tissues are also in the blood vessels and in your heart and your nose and things like that. So some people who are on this medication, about 11% of people can get high blood pressure. That's the
Mm.
most significant side effect of this medication group. So usually we'll check their blood pressure a week or two after they start it, and then just see if it's helping at all. And so, yeah, it's really kind of down to one option as far as pills by mouth go. And for the patients who have either already maxed out on all the self-empowering options, a first line, then it's down to one option. A lot of times people will try to cut back on their caffeine or soda water intake and start a medication at the same time. Sometimes they'll do all three. So they do physical therapy and medication and try to alter the bladder irritants. So everything is acceptable. It just depends on what the patient is looking to do in terms of her bother and how aggressively she wants to see these symptoms go away.
Yeah, and what happens when they're doing all of these and still, are there more invasive or more aggressive options of handling this? And no, particularly a case that comes to mind for me is I had this patient who would just 1 minute she's fine and like full blown bladder spasm emptying itself, right at a traffic light, and it's terrible,
Yeah,
to say the least. So are there like more aggressive options for people who are doing and trying all of these things and still not finding that relief?
absolutely. There are. So there are two options that are kind of on the more advanced side. One is Botox for the bladder. And so it kind of works the same way as Botox for the facial muscles in terms of like wrinkles and stuff like
Hmm.
that, or even Botox for the muscles in the neck for migraines.
Hmm.
It works by paralyzing the muscle of the bladder so that those contractions are not so constant. And so that's one option with its own host of side effects possible. And then the other option is a little bit more like it's kind of like from outer space, it feels like, but it's actually a fantastic option for patients who are really pushed to that level. It's called sacroneuromodulation. It's kind of a mouthful,
Hmm.
but it basically means that we're stimulating the nerves or the nerve root right as it comes off of the spine, because we think that there's a specific nerve that controls the bladder and the bowels. And so we put a small little tiny needle or like a little probe, and we make it touch that nerve. Um, and so that goes through the skin, through all the muscles, in through the back. And that's in the operating room. And then we attach that little thread of a needle to a battery. And then the patient wears that battery on her belt outside her body for like a week. And if over the course of a week with that stimulation, her urinary and or bowel symptoms are better by 50% or more, then we can implant the battery pack so that there's always a impulse or pulse generated. We implant it kind of in a fat pad over the hip. And so that means we're kind of modulating the nerve of the bladder and the bowel so that there's more consistent behavior. It's kind of just like overriding the nervous system a little bit so that it can improve symptoms. And it can be very successful. I had a patient recently who went from peeing 4 times at night, where, having to walk, around town with her bag full of pads, and she would wear them on top of a diaper, to sleeping through the night and just wearing a panty liner for just discharge. So it can be really dramatic.
Yeah.
And a lot of times now, because we're not using that other class of drugs that's we used to use so often, and there's only one group, we are kind of brought up to that option a lot sooner than we used to be.
But, so it sounds like the external battery pack thing is sort of like a test drive to see if this is going to help you. So there is a way of finding if that's actually going to help before you buy into an invasive intervention.
Exactly, that's true. It's a good way to look at it, that it's kind of, you do get a trial period, and if it works, then the way I typically perform the surgery, the needle that is already stimulating the nerve during that trial period will not move. And so then you put the pack in there, the battery in there, and you can expect the same results after. So
yeah, and neuromodulation works even for within physical therapy interventions. There is an electrical stimulation for peripheral nerve.
Absolutely.
And research still strongly backs that up for urgency and overactive bladder. So nerve modulation has been, research is upholding it as a management. So are there any side effects of this, or is this a thing that you put? So the way I explain it to patients is like a pacemaker for your bladder. Mm-hmm. So is it like there forever? Like, can they at one point decide I don't want it anymore? How does that work?
Yeah, for sure. So for a long time, we didn't have a pulse generator that was MRI friendly. It used to be this big magnet, and you can't go in the MRI for any body scans. But now we have one that's MRI friendly. So that's fantastic. That really opens up, who can get this procedure. So yeah, it used to be that if someone had some form of arthritis and they need to get MRIs frequently, that they just couldn't get this. But that's gone now. There is a renewable or rechargeable battery that can be placed now. So depending on the body size of the patient, we can use this smaller battery that can be recharged. Alternatively, we use the older one, which is really maybe just like 2 inches or something like that. 3. It's not very large, but the rechargeable one's even smaller. So if the body size is small enough, then you don't have to have the battery removed and replaced every 5 years. If there are some problems, so say for example, the person has an injury, they fall and it moves into a place that's painful, or in some cases they lose a lot of weight, or maybe they gain a lot of weight, then we need to take it out, then we can. You can never really cross 2 rivers more than once, or 1 river more than once. So it's not always the easiest thing, but it can be removed. Most of the time I try to counsel and convey to patients that it's pretty much a permanent procedure. And so, yeah, I go into it with that mindset.
Yeah, it sounds like there aren't any obvious side effects of this thing, because usually you kind of try it. If it worked, then only you get it. So, before you even put something permanent, there is enough objective data to actually find a reason to place it.
Absolutely. Right. That's what makes it so wonderful, is that you get the time to see if it's going to help you, if it's worth it. And it's really a matter of 2 hours total. So the first hour is to place the small needle, the lead, and then a week later, it's either to remove the lead or place a permanent battery pack. So yeah, you don't get a chance to take a sneak peek at things very often. And so yeah, this is one of those situations with sacral neuromodulation that you can see. And
So how
actually
invasive is sorry, I didn't mean to talk over you. I just wanted to like, how invasive is the procedure of actually putting the battery pack or the needle?
Yeah, so the first needle, the lead, it requires a total, well, all in all, it requires like 3 tiny incisions that are, I mean, smaller than the tip of my finger. And then 1 larger incision that's about 3 centimeters, something like that. So that's pretty much all of it. We work through those tiny holes. We use X-ray in the operating room so we can make sure that in addition to the reflexes that we get from the patient, like her toe, and then the anal wink, that the needle is in on the right nerve. So yeah, so it's not too many incisions. Yeah.
Yeah. And are there any subset of people where this is contraindicated or that's not even an option for them?
The only one that really comes to mind is multiple sclerosis, simply because of the central nervous system abnormalities in that condition. Otherwise, no, I think
Yeah,
it's pretty much wide open. Yeah.
yeah, it's good to have like that as an option for almost everybody, right?
Yeah, yeah.
So now let's talk about Botox. Like it's just so intriguing for me always. Like why, where, how, all of it.
Okay. So Botox is, we basically place it into the bladder. So we use a camera that can fill up the bladder with water as we insert the camera. And then there's also another channel in the camera that goes into the bladder that can hold a needle. And so we make a little grid on the bladder pretty much, and we inject the bladder in like 20 different spots of Botox. And so we spread out the entire dose over 20 spots, and then we're done. And before we inject, we fill up the bladder with like lidocaine solution. We have the patient hold their bladder for a good 10, 15 minutes beforehand so that she can tolerate the procedure. And most of the time it goes without any problems.
Thank you for the lidocaine, because when you said 20 shots, I'm like, ouch.
Yeah. Lidocaine definitely helps. And nowadays we do it in the operating room and it takes even less time. So if the patient needs additional anesthesia, it's just kind of right on hand there.
So is there like a recovery, or do they get Botox shot and go on with life, or what are we talking about?
Yeah, so we make sure they can pee before they go home. And, there are some side effects and some complications like bladder infection and not being able to pee. Sometimes the Botox works so well that a person cannot pee. And usually what we'll do before we decide to move forward with Botox is teach the patient how to empty her bladder with a catheter, or make sure that she has someone near her who can do that in the event that she's in the 1 in 3 people who have that condition of urinary retention. If someone has urinary retention where they can't pee after the Botox, then it usually only lasts about like a week at the most, usually 2 weeks. And so then the effect of the Botox can last anywhere up to a year from the data I've seen, 3 months to a year, with varying effects after that. So it is kind of like a medication that's taken by mouth in that it's a dose. And so until it wears off, you don't have to take it again, but it does require repeated doses usually to have the effect. Whereas with the nerve stimulation, the nerve pulse, the generator is with you. And so it constantly gives you, I guess you would call it a dose, that electrical stimulation.
Mm-hmm. So it varies how long a dose is going to be good for you as far as Botox, and there's always the option of repeating it, which again, sort of is starting at the beginning where whenever is you've reached that level where that's a bother, you can repeat the treatment. Is there such a thing as too many Botox treatments?
I have read about some studies of like kind of exhaustion of Botox. It varies tremendously. I think within a certain 3-month window, there is a maximum dose that one person should have.
Mm-hmm.
But there have been reports that show that Botox is safe up to 9 times, 10 times in a person's life.
Yeah.
So yeah, you could have it many times and it could
Yeah.
be very effective.
Yeah. And it sounds like the biggest thing we're worried about is not being able to empty your bladder fully, right? Like retention. So, are there certain people, like, is there a way to test this before giving somebody Botox that you're probably more likely to have that? Like, how can we watch for that better?
Yeah, that's a good question. It would be nice to know which people are at more risk. A lot of times before we are pursuing these more advanced options, we'll do some office testing like urodynamic studies to see what the bladder is like, how it is when it's filling, how it is when it's emptying, how much is left over. So urodynamic testing is some testing that I offer in the office, and it involves 2 small catheters. One goes in the bladder and one goes in the vagina. And then we fill up the bladder with water and we connect those sensors to a computer that can read the pressures. And then we can see how the bladder behaves as it's filling and how the opening of the bladder, the urethra where it empties, how that behaves. And then we can also see what's going on with the emptying phase. And then, of course, to your question, see how much is left over. And so that can give us an idea that maybe they don't have the best emptying efficiency.
Mm-hmm.
And so we then can weigh the risks and benefits a little bit more accurately. Some people get really queasy with the idea of a catheter at all. But most people who are having these discussions with me are bothered enough by their leakage that
Correct.
they would welcome, any semblance of just like some relief. So
Yeah. So, what's the worst case scenario here? Like, why are we so worried about retention? What could happen if somebody just has bladder retention and doesn't know about it?
yeah, so with the bladder is a low pressure system, so it's kind of operates the best when everything is able to flush out. So anytime there's a blockage of the opening or an inability to contract the bladder muscle, that can cause pressure to back up into the kidneys, and that can cause infection or stones or any number of problems with the urinary tract, and it can damage the kidneys so that they can't work as well to filter out the blood. So we like to keep water flowing down just for the sake of keeping the kidneys at ease.
Yeah, it could be a pretty serious thing, it sounds like, because
Definitely.
if you have lidocaine and sometimes people get busy and they don't remember when was the last time they peed, it can be very easily ignored on a busy day. So
Absolutely.
my last question, I guess, is how do we know who, other than patient preference, is there one kind of person that's better suited for Botox as against neuromodulation, or is that entirely up to patient preference?
Yeah, it's really very patient specific. I consider my job to give patients the options and just kind of lay it out for them. A lot of times patients will self-select. There's some things that they gravitate towards or away from. Just when you offer the full range of options, even some patients with the same conditions or the same severity of symptoms will say, oh, I want a medication, or no, I'm definitely going to go do physical therapy first. And so similarly, patients tend to decide for themselves. I feel like that's just the best it's a very, I think it's a very patient-centered way of practicing, so that the patients are as informed as they possibly can be to decide what's better for them. I try to give them a sense of like the long-term options down the line of what life is like if you do sacral neuromodulation and it works, or what life is like if you do Botox and it works, and short term and long term, and usually the patient makes the best decision for herself. So
yeah, thank you, because that's awesome. I feel like this is such a frustrating process that by at least making their decisions, there's some sense of empowerment, right? Because people usually feel very frustrated with how their body is not doing what they need it to do. So at least having that choice and autonomy in making the decisions of what works for me might give some sense of empowerment back, right? And that can be huge for some people.
Absolutely.
Because it's just like psychosocially it does a number
Yeah,
on you.
definitely.
You're just like, it affects every area of your life. So thank you, that was a lot of information, and I'm hoping people had more clarity on overactive bladder and their treatment choices. And I'm just really very grateful for you taking the time and sharing your knowledge with us. If there are people who want to reach out to you or connect with you, what's the best way to find you?
Yeah, the best way is to call. The office number at my practice is 206-386-3605. My practice name is Urogynocology and Healing Arts. Sometimes I get some questions about what is healing arts. And that's essentially the last thing that we just talked about, which is kind of letting my knowledge be part of something that you can use in your life to heal you, and to heal just in general, to heal patients. So it's not just, oh, here's this prescription and call me in a week. So
I love it. I love it. That's the definition of therapeutic alliance. So I think the name of your practice is very suiting for your approach.
thank you.
I
Thanks.
will
Thank you.
put that in the show notes, like your website. Yeah, any parting thoughts?
Well, I want to thank you for being, on the front lines with me, and helping women become more comfortable and acquainted with their bodies throughout life. It's not an easy thing to do. It's not something that people can even talk about when you call them. It's one of those really private type of topics that we both deal with. If you call a patient back, sometimes she can't really talk to you very much, and you have to give her the words to say yes, blink if you want yes, or whatever, press 1 if you mean no, or something. So we are dealing with really intimate issues, and I just want to thank you and tell you how proud I am of you for kind of putting more words around things that are so hard to talk about.
Yeah, thank you. Thank you so much for the kind words. That sort of is what started this, right? Like, yeah, these issues are more common than you think. But every patient I work with feels like they're the only one struggling with this because we just don't talk about it. For obvious reasons, it's such a private and sensitive topic. But yes, thank you for helping me spread the word.
Yeah, thank you.
Right? There's no such thing as TMI in like what
no, not at all. The bowels and the bladder, bring it on.
Anyway, thank you very much. I hope you guys enjoyed this, and this will be it for today. All right, peace out. Take care.
Thank you.
Bye bye.